Welcome to the deep dive. Ever had a blood test, throw up a result that just made you go, huh?
Happens all the time.
Yeah, well, today we're tackling one of those, thrombocytosis, basically a higher than normal platelet count. It might sound a bit technical maybe, but this little number can actually be a really important signal.
Absolutely. It's like your body sending up a little flag, sometimes a small one, sometimes a bigger one.
A tiny platelet-packed flag.
Exactly. Blood tests give us that sneak peek under the hood, and sometimes a high platelet count is the first sign that we need to look a bit closer.
Right, because platelets, they're the things that stop bleeding when we do cut, aren't they?
That's their main job, yeah. Those amazing little cells rushing to the scene. So if the numbers are off, especially high, it's definitely a story worth digging into.
Okay, so our mission today really is to make thrombocytosis clear for you listening. We want to break down what it is, what might cause it, what the risks are, what it all actually means.
That's good.
And we'll be using our notes here to really get into the details. Now, right away, you mentioned there are two main types.
That's right. It's crucial to know there's primary and secondary thrombocytosis. We'll definitely unpack both of those.
Okay, let's start right at the beginning then, the definition.
Oh, okay. So thrombocytosis, simply put, it's having an abnormally high number of platelets in your blood, usually picked up on a routine blood test, a CBC.
A complete blood count, right?
Yeah. And the really key thing is distinguishing primary, sometimes called essential thrombocythemia, where the problem starts in the bone marrow itself, from secondary or reactive thrombocytosis. That's where the high platelet count is, well, a reaction to something else going on.
Okay. And why does it matter? What's the main concern?
The main concern generally is an increased risk of abnormal blood clots. That's thrombosis.
Right. Dangerous clots.
But interestingly, in some cases, particularly very high primary thrombocytosis, you can actually see the opposite too, an increased risk of bleeding.
Wow, okay. Bit of a paradox there.
It is. And that primary type you mentioned, essential thrombocythemia, that's a specific condition.
Ah, right. Tell us more about that one.
Precisely. Essential thrombocythemia, or ET, is defined by having that persistently high platelet count, usually over 600 times 10 to the 9 per liter. It's classed as a myeloproliferative neoplasm.
Okay, myeloproliferative neoplasm. Bit of a mouthful.
It is. Think of it like the bone marrow's platelet factory just gets stuck in overdrive. No proper off switch.
Gotcha.
And this can lead to that sort of double-edged sword, higher risk of clots, but also sometimes higher risk of bleeding or hemorrhage.
Right.
Some people with ET also mention a weird burning or tingling feeling, often in their hands or feet. And genetically, about half of them have a specific mutation, something called the JAK2 mutation.
JAK2. Okay, we'll probably come back to that. So let's dig into the why. What actually causes these different types? Primary first.
Okay, primary thrombocytosis, or ET. As we said, it's a myeloproliferative neoplasm. Essentially, the bone marrow is just making too many platelets, and there isn't an obvious external reason for it.
So the problem originates in the marrow.
Exactly. The count's usually over 600. If you looked at the bone marrow itself, you'd see more of these really big cells, the megakaryocytes. That's Megakaryocytehyperplasia.
Okay.
Often the spleen might be a bit bigger, to splenomegaly, and there are those increased risks of clotting and bleeding.
And the platelets themselves, are they normal?
Well, their lifespan is usually normal, but their function, that can sometimes be a bit impaired, a bit faulty.
I see. And can it be linked to other things?
It can sometimes be associated with other blood conditions, like myelodysplastic syndromes, or even some types of leukemia.
Okay, so that's primary. The bone marrow itself is the issue. What about secondary or reactive? You said that's different.
Completely different ballgame, yeah. Secondary is the body's response. The bone marrow ramps up platelet production temporarily because it's getting signals from somewhere else.
Signals? Like what?
Well, think about times of stress for the body. Severe infection, maybe after major surgery. The body releases these things called acute phase reactants.
Ah.
Right.
Like CRP levels going up.
Similar idea, yeah. Or even something quite common like iron deficiency, anemia can trigger it. It's often mediated by chemical messengers called cytokines.
Cytokines, okay.
The body releases these when it's under stress, fighting something off. But the key thing with secondary is it's usually temporary.
Ah, okay, so it goes away.
Generally, yes.
Yeah.
Once you find and treat whatever triggered it, the infection, the inflammation, the deficiency, the platelet count should settle back down to normal.
That's reassuring. So what kind of underlying conditions are we talking about here? Can you give some examples?
Oh, the list is pretty long, actually, which just shows how many things can stress the body out.
Right.
So you've got various inflammatory conditions, lots of different infections, bacterial, viral, fungal.
Mm-hmm.
We mentioned iron deficiency. Also, certain cancers can cause it. Having your spleen removed post-splenectomy
Yeah.
after surgery or significant trauma.
So basically, anything that really throws the body off balance could potentially do it.
That's a good way to put it, yeah. Anything that disrupts that normal equilibrium.
You mentioned genetics earlier, particularly with the JAK2 mutation in primary. How much do genes play a role overall?
They're definitely significant, especially in primary forms. We see mutations in genes that control thrombopoietin. That's the main hormone telling the marrow to make platelets.
Okay.
Two key genes are MPL and JAK2. Mutations there are common in essential thrombocythemia, but also in related conditions like primary myelofibrosis, sometimes even in hereditary thrombocytosis where it runs in families.
And that JAK2 one, V617F, was it?
That's the one, JAK2 V617F. It's fascinating because having one copy of the mutation, being heterozygous, tends to push towards making too many platelets, like in ET.
Right.
But having two copies being homozygous can actually lean more towards other conditions like polycythemia vera or myelofibrosis. So the same mutation can have different effects depending on the dose, essentially.
Huh. Genetics is complicated. So, okay, risk factors. If someone has thrombocytosis, what makes them more likely to have problems from it?
Well, for primary thrombocytosis, it often just happens. There aren't usually clear external things that trigger it, which is why it's primary.
It starts from within.
Exactly. But for secondary, the risks are really tied to whatever the underlying cause is. So things like older age, how severe the infection or inflammation is,
Yeah.
that can play a role.
And does personal history matter? Like if you've had clots before?
Definitely. In both primary and secondary, if you have a personal or even a strong family history of blood clots or bleeding disorders, that could potentially increase the risk associated with the high platelets.
Okay. Let's get into the nuts and bolts, the pathophysiology, what's actually happening inside the body.
So in primary, like we said, it's often that genetic mutation messing with the signals inside the bone marrow cells leads to that uncontrolled production. The internal controls are just off.
Faulty wiring, kind of.
Sort of, yeah.
Right.
Whereas in secondary, it's all about the body's response to something external. Inflammation happens, cytokines get released. Those cytokines tell the bone marrow, hey, make more platelets. Sometimes the body might also not be clearing out old platelets as efficiently. It disrupts that normal balance of making and removing platelets.
Got it. So a doctor sees high platelets on a test. How do they figure out which type it is? And are there other conditions that look similar? What's the differential diagnosis?
Yeah, that's a super important step. Seeing that high number, especially if it stays high, means you have to think broadly. First, are there primary blood or bone marrow causes?
Okay.
Obviously, primary thrombocytosis itself, but also other myeloproliferative neoplasms, things like polycythemia vera, primary myelofibrosis.
Right.
Then there are myelodysplastic syndromes, refractory anemia, chronic myeloid leukemia, CML,
Okay, quite a list.
chronic myelomonocytic leukemia, atypical CML, and a kind of catch-all category. MDS-MPNU, which is myelodysplastic myeloproliferative neoplasms, unclassifiable.
Wow. So lots of specific blood disorders to rule out for primary causes.
Exactly.
And what about the secondary, the reactive causes? You said that list was even longer.
It really is, because so many things can trigger that reactive rise. We're talking all kinds of infections: bacterial, viral, fungal, parasitic,
Right.
any inflammatory condition, rheumatoid arthritis, inflammatory bowel disease, tissue damage, like from surgery or a major injury, problems with the spleen or after it's removed, that post-operative period, significant bleeding or hemorrhage, iron deficiency, again,
Right.
various cancers, hemolysis, where red blood cells break down too fast. Certain medications can do it. Even getting cytokine therapy itself. You can get a rebound high count after stopping chemo that suppresses the marrow. Some kidney disorders. And it's actually quite common in premature babies or those with low birth weight.
So the patient's story, their whole clinical picture is absolutely key then.
Absolutely crucial. You need that history and exam to even begin sorting through that list.
Okay. Given how many potential causes there are, especially secondary, how common is thrombocytosis overall? What's the epidemiology look like?
Well, primary thrombocytosis, specifically ET, is actually the most common of those myeloproliferative neoplasms we listed.
Oh, really?
Yeah. The estimates are roughly maybe 40 to 60 cases per 100,000 people. It seems to be a bit more common in women, and it definitely gets more common as people get older. Peak diagnosis is often around 50s or 60s.
Okay. And secondary?
Secondary is much, much more common overall. Interestingly, the highest rates are seen really early in life, like the first 3 months. Preterm infants are particularly susceptible.
Wow. Didn't expect that.
Yeah, but beyond infancy, you see secondary thrombocytosis popping up in all sorts of situations wherever there's inflammation, infection, cancer, trauma. So it's really widespread across all ages, unlike the more specific demographic for ET.
Right. So if someone does have a high platelet count, what might they actually notice or feel? What are the clinical features?
Well, first thing to say, and this is really important, is that often it's found completely by chance on a blood test. The person feels totally fine, no symptoms at all.
Okay. An incidental finding.
Exactly. But the symptoms, if they do occur, can vary a lot, depending on if it's primary or secondary and if any complications have started.
Let's focus on primary, on ET first.
Yeah.
What might someone experience there?
Okay. So with ET, some people might find they bruise or bleed more easily, but usually it's not severe unless the count gets incredibly high, like over 1,000.
Over 1 million platelets per microliter.
Yeah, way up there. Paradoxically, though, the bigger risk is often thrombosis, those clots. They can happen in small vessels, large vessels, arteries, veins. About 20–30% might get what we call constitutional symptoms, things like night sweats, maybe a low fever, sometimes itching, which can be quite bothersome. But significant weight loss isn't typical.
Okay. What about neurological things?
Headaches are pretty common. That burning pain and redness in hands or feet, erythromelalgia, sometimes mini-strokes or TIAs, pins and needles, dizziness, slurred speech, fainting, migraines, rarely even seizures.
Wow. And clots in arteries or veins.
Yeah, arterial clots can hit the heart, kidneys, legs, causing pain or even tissue death like gangrene in toes or fingers. Venous clots can happen in the abdomen, splenic, or hepatic veins, legs, pelvis, rarely priapism or pulmonary hypertension from clots in the lungs.
And bleeding. You mentioned that too.
Yes, when bleeding happens, it's often in the GI tract, maybe mimicking an ulcer, but could be eyes, gums, skin, urinary tract, joints, even the brain.
Goodness. And for women. Pregnancy.
Yeah, pregnancy with ET has higher risks, spontaneous abortions, especially early on, problems with the placenta affecting the baby's growth, very rarely excessive bleeding during delivery.
And what might a doctor find on examination?
Well, they might feel an enlarged spleen in maybe 40–50% of people with ET and maybe an enlarged liver in about 20%. But often the physical exam can be pretty normal otherwise.
Okay, that's a huge range of potential issues for primary. How does secondary thrombocytosis present differently?
With secondary, the symptoms are really driven by whatever's causing it. So if it's a bad infection, they'll have symptoms of infection. If it's inflammatory bowel disease, they'll have gut symptoms. The key difference is that those specific constitutional symptoms, the sweats, the fevers, the itching, and the neurological things like erythromelalgia, they're usually absent in secondary cases.
Okay. And the physical exam?
Typically, there's nothing specific on exam that points directly to the secondary thrombocytosis itself. The focus is all on finding clues for that underlying root cause.
Makes sense. So if thrombocytosis is suspected, what tests does a doctor order to investigate?
Okay, first step is always confirm the count is definitely high, usually over 450 in adults, and stays high on repeat tests.
Right, not just a one-off blip.
Exactly. Then the big job is figuring out primary or secondary. Is it a chronic bone marrow thing or is it reactive?
How do they do that?
Starts with that detailed history, any other illnesses, infections, recent surgery, plus a thorough physical exam looking for clues, then blood tests. For primary, if secondary causes seem unlikely, you're looking for that sustained high count, often over 600. A bone marrow biopsy is usually key.
Looking in the cells directly.
Yep. Looking for too many megakaryocytes, maybe abnormal shapes. Clotting tests, platelet function tests might be done. Checking red cell mass helps rule out other conditions like polycythemia vera. Basic blood chemistry can show high uric acid or B12 sometimes. And genetics are crucial, looking for JAK2 MPL mutations, ruling out the Philadelphia chromosome for CML, maybe imaging like a chest x-ray or abdominal ultrasound.
Okay. And for secondary?
For secondary, the tests are all aimed at finding that trigger. So inflammatory markers like ESR, CRP, tests for specific infections, imaging to look for cancer or inflammation. It's guided by the history and exam.
Got it. So once you have a diagnosis,
Yeah.
how is thrombocytosis managed?
Management really depends heavily on whether it's primary or secondary, and also on the individual's risk factors for clots or bleeding and if they've already had complications.
Okay, let's take primary ET first.
For ET, it's tailored to risk. If someone is considered high risk, maybe over 60, or they've had a clot before, they'll likely be offered cytoreductive therapy. That means medication to lower the platelet count.
Like what kind of medication?
Commonly hydroxyurea or sometimes interferon alpha.
Okay. And for low-risk people?
Low-risk patients might just be managed with low-dose aspirin to reduce clotting risk.
Makes sense.
And general advice for everyone with ET is important too. Manage weight, control blood pressure, diabetes, cholesterol, all those cardiovascular risk factors.
Right.
In those high-risk cases needing platelet reduction, besides hydroxyurea and interferon, another drug called anagrelide might be used.
Anagrelide.
Yeah. And if someone has an acute serious clot, like a stroke, sometimes they need plateletpheresis, a procedure to quickly filter platelets out of the blood.
Wow. Like dialysis, but for platelets.
Kind of, yeah. And usually cytoreductive therapy is recommended before any planned surgery to lower the risks during the operation.
Okay. And what about managing secondary thrombocytosis?
For secondary, even if the counts get really high, sometimes over 1,000, the main focus is always treating the underlying condition.
Find the cause, treat the cause.
Exactly. You treat the infection, manage the inflammation, correct the iron deficiency, whatever it is. Once that's under control, the thrombocytosis usually resolves by itself.
So you don't usually need specific platelet-lowering drugs?
Not typically, no. Maybe low-dose aspirin is considered in some specific high-risk situations, but the core strategy is treating the primary problem. And obviously, you manage any complications from that underlying disease.
You mentioned a few drugs for primary ET, hydroxyurea, anagrelide, interferon. Any others?
Yeah, those are the main ones. Interferon alpha is sometimes preferred, for example, in younger patients or during pregnancy, as it's generally considered safer in that context. Less commonly used now are older agents like busulfan, radioactive phosphorus, or pipobromin, usually reserved for specific situations or older patients.
And what's the goal of treatment? How low do you want the platelets?
The general aim is usually to get the platelet count below 450, but the specific target and the choice of drug, the dose, that's all very individualized. Depends on risk, age, other health issues, patient preference.
So it needs careful assessment and monitoring.
Absolutely. Regular checks, blood tests, managing risks. It's a comprehensive approach.
What about the long term? What's the prognosis like for someone with thrombocytosis?
It really varies. Depends hugely on the underlying cause, primary versus secondary, any complications, and how well treatment works.
Okay.
Generally speaking, primary thrombocytosis, ET, often has a better prognosis than secondary. Why? Because secondary is often linked to serious underlying issues like advanced cancer or severe chronic diseases.
Right, the prognosis is tied to that condition.
Exactly. For ET itself, many people live a long time, but there might be a slight reduction in overall life expectancy compared to average. And having a high white blood cell count along with the high platelets can sometimes worsen that outlook slightly.
And for
Prognosis is almost entirely dictated by the primary disorder. Also worth noting, in some cancers, breast, ovarian, kidney, lung having thrombocytosis seems to be linked with a poorer prognosis for the cancer itself.
Interesting. Okay, finally, let's talk complications. What are the main things that can go wrong?
The biggest worry across the board is thrombosis. Increased risk of blood clots forming where they shouldn't. There's also that potential bleeding risk, especially with super high counts in ET, but clotting is generally the more frequent concern. So catching it early and managing it properly is key to try and prevent these.
Got it. Any specific complications for primary ET?
Yes. Serious, sometimes fatal clots can happen, including in less common places like the splanchnic veins in the abdomen. Bleeding, often GI tract, but usually less severe than the clots.
Okay.
And there's a small but real risk, maybe 0.5%, up to 5% over time, that ET can transform into acute myeloid leukemia, AML.
A type of leukemia.
Right, yeah. Though some evidence suggests that risk might be lower with interferon or hydroxyurea compared to older drugs like alkylating agents.
And complications in secondary thrombocytosis.
With secondary, problems directly caused by the high platelets themselves are actually less common than problems caused by the underlying condition that triggered the high platelets in the first place.
So the focus remains on the primary illness.
Primarily, yes.
All right, let's try and pull this all together. Key takeaways for you listening. Thrombocytosis means a high platelet count. Big question is it primary, starting the bone marrow, or secondary, reacting to something else?
Exactly. And figuring out that underlying cause, especially for secondary, is absolutely vital.
Yeah. So while seeing a high platelet count on a blood test might just seem like, an odd number, understanding where it might be coming from and what the risks are, That's a really crucial piece of the health puzzle.
Definitely makes you think.
It does. Makes you wonder, what other routine blood results might be telling us more than we initially realized?
Good question.
Well, for those of you who want to dive even deeper into topics like this, maybe if you're studying medicine or preparing for exams like the MSRA, definitely check out passthemsra.com and also freemsra.com. They're fantastic resources for learning and revision.
Great resources.
Thanks so much for joining us for this deep dive today.